Professor Shilpa here talk about tomosynthesis guided biopsy. Professor Shilpa, she's a consultant radiologist, breast imaging and intervention, NM, Medical Center, Bombay, India, core committee member, Breast Imaging Society of India former, staff radiologist, Women's Breast Health Center, the Ottawa Hospital, University Ottawa, Canada, India. Her speaker, her talk about tomosynthesis guided biopsy. You're welcome, Professor Shilpa.
Thank you very kindly. Thank you at the outset for inviting me here at this conference. My dear friend Rasha Kamal, Merital Madvi, all the honorable members on the dais, everyone in the audience, and Dr. Hesham Al-Ghazali for organizing this wonderful conference for the benefit of the women of the world. Without any further ado, the topic for today is 3D tomosynthesis guided biopsy. We just heard a wonderful talk by Dr. Mike Linver on tomosynthesis detected lesions. These are lesions which are seen only on tomosynthesis. Nonetheless, they are very, very concerning. So how do we deal with them? That's the question at hand. Okay, here are my disclaimers. And I would like to dedicate this talk to my beloved Sadhguru, Sri Vaman Raupai. And the objectives for today's talk. What do we deal with? What are the indications for 3D tomosynthesis guided biopsy, advantages over stereotactic biopsy, and the procedure? So in this next few minutes, I will be demonstrating this procedure on Amulet Innovality, which is a Fujifilm equipment, and the ENCORE device by BD Bard. But more or less, given the small differences in this equipment, the standard procedure for most vendors remain the same, okay? The biopsies that we obtain are with vacuum-assisted biopsy predominantly, but sometimes we are also using core biopsy for a simple reason that cost becomes a big issue in India. Patients are paying through their own pocket for these procedures, and the difference in cost between the two procedures is 50%. So whatever is the cost for tomosynthesis guided VAB procedure, the cost for tomosynthesis guided core biopsy is half of it. So sometimes we have to take this call. Okay, before I go ahead with showing the actual technique, this basic knowledge about stroke margin is important. This is similar to what we were used to with the stereotactic vacuum biopsy as well. Why is it important? Because this is one of the limitations that you may come across when you're trying to position a patient, especially with the lesion being closer to the skin or sometimes the breast being too thin. Why does that happen? Let's have a look. So with our vacuum-assisted biopsy, the breast is compressed between two paddles. Like we are seeing in this case, what happens is the breast is compressed. Say it is the total, after compression, the thickness of the breast is 59 millimeters. This is where our microcalcifications are located. So based on the location of the microcalcifications, the depth of the target from where the entry point of our needle is, for example, 51 millimeters, okay? Now the point to understand here is, with a VAB needle, the opening from where the samples will be obtained, the center of this aperture is about 1.9 centimeters from the tip of the needle, okay? And this total aperture is about 1.9 centimeters, okay? Why is this important to understand? In addition to this, there is one more thing. The thickness of our compression paddle is about 12 millimeter, which means we are dealing with a total thickness here such that after we subtract the total thickness of the breast from the site where the microcalcifications are. So if the total thickness is 59 millimeters and where the microcalcifications are located is about 51 millimeters, then we need a stroke margin of at least 7 millimeter. Why is that? Because the center of this aperture is about 1.9 centimeter, And this thickness of the compression paddle is about 12 millimeters. So therefore, we have a dead space of about 7 millimeters. This is how much the dead space is, where the needle will be going beyond the microcalcifications. Therefore, when you look at your total compression minus the Z, that is the location, the depth of the microcalcifications or architectural distortion or asymmetry, the difference should at least be 7 millimeters or more. Only then you will be able to proceed with your procedure. Now that is the most important step about stroke margin that I had to explain here. Now what is the role of core biopsy? Like I said earlier, due to cost constraints, sometimes we use core needle biopsy. Okay? Indications for tomo-guided biopsy, masses or architectural distortions which are seen only on 3D tomosynthesis, or basically any lesion which is visible on mammography. All the indications for which we were doing stereotactic biopsies so far, we can do tomo-guided biopsies. But the question remains, why should we do that? Is there any good reason for converting our entire practice from stereotactic vacuum biopsy to tomo-guided vacuum-assisted biopsies, even for microcalcifications? So here is an impressive study. Okay, I'll show you the study in a minute. But the important point to understand is 90% of architectural distortions are better seen on 3D. Of these architectural distortions, 12% with no sonographic correlate will be malignant, and about 12% with sonographic correlate will be malignant, and about 7.7% with no sonographic correlate will also be malignant. Therefore, the tomosynthesis guided biopsy becomes important. As in this case, we see an asymmetry which corresponds to an architectural distortion on tomosynthesis. This is what we call a black star, and this turned out to be a radial scar at vacuum-assisted biopsy. In this case, however, this architectural distortion was more sinister. We did not have a sonographic correlate, and this turned out to be an invasive lobular carcinoma. Not being able to do this biopsy would have been a loss of not being able to diagnose the invasive lobular carcinoma in time. What are the microcalcifications which can be biopsied? Grouped pleomorphic, linear segmental, or regional microcalcifications. Okay? Now, is there an advantage of doing a 3D VAB versus a stereo VAB? Here is a study by Dr. Christiana Kuhl and her group. What they did was they looked at about 159 patients who had undergone stereotactic VAB and about 46 patients who had undergone a 3D tomo-guided VAB. Okay? And what they found was the technical success was 100% when they did a 3D VAB as against a stereo VAB. Stereo VAB also had a high success rate at about 93%. However, the big difference was the procedure time. Procedure time for a tomo VAB was about 13 minutes as against a stereo VAB which was about 29 minutes. In half the time, you can do the same procedure. Most non-calcified lesions are better identified, like architectural distortions, but even microcalcifications, you have no problem, except for the faint amorphous ones. Most other microcalcifications are very well seen. Okay? So no requirement for triangulation, target lesion re-identification, sampling of non-calcified lesions, and 100% success rate in half the procedure time. So what more could we ask for? Okay, so I'm going to show this procedure to you because seeing is believing, literally. Okay, so here we go. So these are the microcalcifications that we are about to target. Okay, our landmark was this benign popcorn calcification, and this is the cluster of new pleomorphic microcalcifications that we saw on the recent screening mammogram. When we do a tomosynthesis guided biopsy, we actually obtain a tomo slice of the field of view, and that's exactly what we have done here. This is the tomosynthesis slice, complete slice. So I'm going to scroll through the whole thing so that the audience gets an idea about what we actually do. So we scroll through that entire area, the whole stack of images, and on this stack we notice that these are the pleomorphic microcalcifications that we see, which are adjacent to the benign popcorn calcifications. This is the benign popcorn calcifications, and these are the pleomorphic microcalcifications that we want to target. Now we target this area. Okay, this is what we do, and then we select the needle that we want. Okay, so the way the needle selection is done is from here. We have an entire set of selection from which we can do. So I'm just going to show you what all we have. We have the marquee 12 gauge 10 centimeter needle with a 18 millimeter throw, another 12 gauge 10 centimeter with 25 millimeter through, the 14 gauge needles with the 22 millimeter through, 16 gauge or 10 gauge VAB. So that is exactly what we are going to select right now. 10 gauge vacuum assisted biopsy. This is what we select, and these are the targets that are showing. After we have selected those microcalcifications, X, Y and Z target. Okay, so once we know these targets are acceptable with the barred 10 gauge vacuum biopsy, we send these targets to the machine. Okay, so the machine is showing us basically here that this is where our microcalcifications are located, and that is the total thickness of the breast, which is about 38 millimeters. Okay, and this is our Z, which is the depth. The X and Y has already been coordinated. The depth that we need to go is 31.1 millimeters. So once we say send on this screen, we get the target on the machine. Okay, so now we'll move towards the machine. Okay, on the machine we are seeing the targets right here, and we just do OK here. Okay, and it asks us if it is okay to go vertical, and we say OK. Okay, then what we do is the X and Y is selected here, and this is the Z. The Z is accounting for the thickness of the breast as well as the depth within the depth of the microcalcifications within the breast. So now we go to target. Okay, after we go to target, notice how this is moving. The X, Y is moving. And the Z is also coming down. Okay, so the Z also comes down. Now once we know everything is zeroed, and how do we know that? On the screen, the target shows us that the X, Y and Z coordinates have been zeroed in. Okay, once all this has been zeroed in, then we do our next steps forward. We attach the guide that we need for mounting our 10 gauge needle. Okay, so this guide has been attached. Okay, and we bring the guide approximately to the spot where we are going to target. Okay, and the next step is we clean the skin right here. The skin is cleaned with normal betadine solution. Okay, once the skin is cleaned, we're going to give a whole bunch of local anesthetic. We typically give a combination of 5 ml of lidocaine. So a little small little bleb on the skin, sorry. You will feel a little sharp sensation and a burning sensation now. Okay, are you with me so far? Are you okay? Very good. If there is any pain or any discomfort that you feel, please indicate by raising your hand. Okay, now I'm going to go deep into your breast. Okay, I'm going in deep. You're going to feel a small burning sensation. Try not to move. Are you well? Are you okay? Okay, the next one that we give is lidocaine with epinephrine. This kind of controls the bleeding. Okay, so we give that about 5 cc's. Okay, it's going to be numb now. Okay, you're doing very well. Okay, and the last one that we give is bupivacaine. Bupivacaine is the longer acting local anesthetic. And it kind of helps for a little longer than lidocaine or lidocaine with epi. So that's another 5 cc. So total of 15 cc's is what is given. Okay, at this point, because 15 cc's of local anesthetic was given, it is a good practice to get one set of images again, and that is what we practice, because sometimes the microcalcifications move. So now we're going to go back to our screen and get that second set of images. I'm going to remove the guide right here, and we're going to take those images. Come, let's go back there. Okay, so we'll take a second set of images here. Okay. Yeah, we've got those microcalcifications. They have probably moved a teeny tiny bit, and we will know that from our target. So if you notice, this is where we had initially targeted, okay? And if we scroll here, do we see those microcalcifications in that spot? Yeah, more or less the microcalcifications are in that spot, okay? So we are good to go, okay? So again, we will select, and this has already been selected because this has already been sent to the machine. So now we will go target. The guide is back in place, and now with the vacuum biopsy, we are going to select on the screen here the complete 360 degree, okay, so that once the needle is in, it goes all the way around. We will load the vacuum needle. So the vacuum needle has this part. This is the opening from where it is going to obtain its samples, and this is the spot. This red marking shows exactly where it is going to obtain the sample while it rotates through the 360 degrees. We're going to mount this on the machine here.
I need somebody with me.
Okay, so we're almost there. We're almost there. We're going to mount this up here. Are you okay? Are you okay? Are you perceiving any pain?
No, I'm
No.
feeling very hot.
Hot? Okay. This is only going to take about a minute. Okay. Are you dizzy?
No, I'm okay.
You okay? Okay. This will take
I
only
just need
about a
break,
minute. Yeah?
Yeah.
Yeah. Okay. So you may feel a little bit of a vibration, but that's about it. You shouldn't feel any pain. Okay. So let me know how you're feeling right now. Are you all right, eh?
Yeah.
Okay, great. Excellent. You're doing very well. So all that is happening now is the VAP needle is obtaining samples in 360 degrees. Okay. And every time the red mark moves, we know it has moved on to the next spot. So it obtained from 12 o'clock, 2 o'clock. Now it's gone to 4 o'clock. And through the process, I'm holding on to a foot paddle so that it goes all the way in 360 degrees. Okay, so now we are at 6 o'clock. After the 6 o'clock is done, we're going to be at 8 o'clock right here. Okay, so we are almost there. We have obtained 5 samples, and then the last sample at 10 o'clock. Okay, so once these 6 samples are obtained, we're going to stop right here, and we're going to check if we have got the optimal sampling. Okay, so before we do that, we unmount the VAB probe along with the needle from. So now this is the post procedure tomo slice, and in this when we scroll through the slice, we notice that the microcalcifications that were seen before have been completely removed. Okay, we continue to see that coarse popcorn calcification right here, and cavity at the spot of the microcalcifications that were there. So this is a successful procedure, but that also means that we need to leave a marker clip at the site of the biopsy, such that if this comes positive for malignancy or pre-malignant lesion, then the surgeon should know exactly which spot we have biopsied. So now we are going to deploy a marker clip at the site of the biopsy. This marker clip is a coil-shaped marker clip. So let's open, and this is specific for a stereotactic or tomo-guided vacuum biopsy. What we do is we are going to remove the basket from the rear end. This basket is removed. The basket has the sample in it. Okay, we're going to take a specimen sample as the next step after deploying the marker clip. And from the rear end here, we will be deploying the marker clip. So to do that, what I'm going to do is, first we will mount this. So this is being mounted, okay. Now once this is mounted, what we do is, we deploy the marker clip. This is the marker clip, which gets deployed from this rear end right here, okay. It goes in all the way. What we're going to do is, we're going to take select marker in here, okay, and that kind of opens up the whole thing. You can show it right here. So now it has opened up, okay. It will help us engage this further, okay, and we push it down really like a ballpoint pen. Once it is pushed down, then again we rotate it from the machine right here, okay, just to make sure it gets deployed in the spot. Just as a precautionary measure, I like to rotate it 2 times. It's not necessary absolutely, but we rotate it 2 times. And then once this is done, we're going to unengage the entire assembly here, okay, and just put the little cover back. This is a safety cover, so do not discard it. And the last step of this particular procedure is to make sure that the marker clip has got deployed. That's our little fiducial marker clip, and it's in a good spot within the cavity. Okay, so this is all successful, done. Now the last part, which is specimen radiograph. So now we are going to obtain the entire sample. So this is the basket. The entire purpose is so that we are able to look for microcalcifications in this specimen. A specimen radiograph now. Okay, so let's see. Here you go. Bring it down, Baba. Now this is the specimen radiograph, and we see all these microcalcifications within the specimen. So this is a successful procedure. Once we have confirmed that the sample has microcalcifications, we dump it into a jar of formalin so that it can be sent to the pathology department. So this is the pre-procedure image with the coarse popcorn calcification and the new pleomorphic microcalcifications, and this is the post-procedure image where we see the coarse popcorn calcification. Most of the pleomorphic microcalcification have been removed, and the coil-shaped marker clip is seen in its spot. This is seen in the CC projection, okay, and the same in the ML projection. Here we have the pre-procedure mammogram with the coarse popcorn calcification and the pleomorphic microcalcification superior to it, and here we have the post-procedure mammogram with the coarse popcorn calcification and the coil-shaped marker clip superior to it. So yeah, so those were the steps. Because I'm talking, it took about 14 minutes, but really speaking, it actually takes about 9 to 11 minutes to do this complete procedure. So it really saves on time. The accuracy is unparalleled, okay? And in cases of tomosynthesis guided core biopsies also, simply because those architectural distortion may sometimes be associated with a small little mass there, we find that our accuracy is pretty good. Now, if I wonder whether
So these are the microcalcifications.
and whether I'll be able to show the second video. It's really short, about 4 minutes. Do I have the time or?
As I scroll through the area,
Yeah, it's okay. Okay, so first we'll take any questions, like to conclude the actual procedure. 3D tomosynthesis detected suspicious architectural distortions, small masses. 3D tomosynthesis, excellent procedure. Clinical performance is superior to that of stereotactic VAB in terms of 100% success rate, half the procedure time. Okay, can we do a 3D core for like a core biopsy? It remains to be seen because there are not as many publications talking about a core biopsy for architectural distortions because vacuum biopsies are so easy to do. But in countries where we still struggle with economics in medicine, we really have to continuously improvise and problem solve, and therefore the attempt to do core biopsies. And so far our results have been good, even with core biopsies, 12-gauge needles. I wonder if you guys have some similar experiences to share. And I'm happy to take any questions regarding the procedure, if there are any. End
yes,
of the
at the end.
session. So I leave you with this thought here. Virtue for the prudent man lies in moderation between excess and deficiency. And when we do any new procedure or we do alterations from what has been advocated, we have to first remember that first do no harm. We all took that oath, so we want to remember that. And I would like to thank all my friends here in Egypt, Rasha, Merit, Dr. Salim, and a lot of you whose names I may not remember, but you're all in my heart. So thank you very much for having me back in Egypt.
Thank you, Dr. Shilpa Lad, for your very well demonstrated presentation. And now I will call again for the Professor Rasha Kamal to give us a new and interesting